Good afternoon, everyone. Good morning, good afternoon, depending on where you are in the state. My name is Julie Babbage, and I'm the Executive Director of the Diabetes Patient Advocacy Coalition. On behalf of DPAC, welcome to the Kentucky Diabetes Advocacy Forum. We've hosted this advocacy series in several states so far, but I can't tell you how excited I am that we can bring this to my home state of Kentucky. I'm coming to you live from Louisville this morning and the snowpocalypse. So we hope that everyone is staying safe out there. If you have to drop for any reason at any time, this meeting is being recorded and will be shared after. So thank you to those of you joining us today. We have an audience both here on Zoom and on Facebook Live, representing folks from across the diabetes community. We have type 1, type 2, parents of children, others with connections through family and friends. And we'll share more about the audience with you as we go on. But we have some data that you submitted during your registration, and I will share more about that as we look at our agenda, which begins with an introduction and then moves to two legislators in Kentucky who are well known for their work on health issues and diabetes. That's Senator Alvarado and Representative Bentley. Just about a quarter or so of you indicated that you had met with a legislator before. So after today, you can say that you have. Next is our health panel. And we are so fortunate to have two outstanding women, one with the Cabinet for Health and Family Services and the other from the University of Kentucky Barnstable Brown Diabetes Center. This panel will focus on two major topics, that's diabetes education, as well as Kentucky's program to offer assistance for prescriptions like insulin. And that's very relevant for many of you on the line today, as about 20% of you said that you had rationed your insulin before. And then we'll dive headfirst into our Advocacy 101, which includes action that you can take in Kentucky right now, and a cheat sheet on hot topics or key issues that are most critical for people with diabetes and how you can get involved. And then we'll wrap it up with next steps, all in just about 2 hours. Now that we have introduced ourselves, let's transition to our first panel, the legislative overview. I am going to introduce our moderator while the panelists turn on their cameras so that we can have them on the screen. Bob Babbage is the managing partner at Babbage Co-Founder, a government affairs firm based in Kentucky and Washington, D.C. that has been an advocate for diabetes for over 20 years. Bills he's worked on in the State House include several that have become national models copied by other states, including in Kentucky, the first ever diabetes action plan and the first bill to establish licensure for diabetes educators. Bob served in elected office as Kentucky's state auditor and secretary of state. We do share a last name. He is my father, and diabetes is a family passion and a cause of ours. So thank you for joining us, and I will turn it over to you to introduce our panelists.
Thank you, Julie, and thank you all, champions all, for being here today. I'm thrilled to introduce two people for whom I have the highest regard. Are we all on the screen there? Both these gentlemen have dual titles that they have earned, one by way of public election and re-election, and the other by way of rigorous academic endeavor. Dr. Alvarado, you see on the left of the screen, is an internal medicine physician in Winchester, Kentucky. And Dr. Bentley, Representative Dr. Bentley, is a pharmacist out in Russell, Kentucky. Both have been extremely active and leading on diabetes issues. So while Congress takes some heat for not acting quickly enough, these two and their colleagues are very well focused on diabetes and what to do. These two gentlemen co-chaired the Diabetes Emergency Medical Response Task Force back in 2018. We'll tell you more about that as we go along. Let me start with some formal introductions. First, Dr. Alvarado, who represents the Lexington area, Fayette County, Clark County, Montgomery County. Among his committee assignments are chairing Health and Welfare, significant committee, along with the Medicaid Oversight Committee. He was elected in 2014. He was the first Hispanic member of the Kentucky General Assembly. As mentioned, Dr. Alvarado came to this leadership post in part because of his medical background, a bachelor's degree in biology, as well as a doctorate from Loma Linda University in California, and fortunately a residency in internal medicine and pediatrics at UK. Dr. Bentley represents Eastern Kentucky, the Ashland area, great cities like Graceland and Flatwoods, Boyd and Greenup counties, located in the East. First elected in 2017. I met him a long time ago. He was a couple of years ahead of me in college and way ahead of me academically. He chairs the Budget Review Committee that looks at all of Health and Family Services and serves on 4 additional committees. He has a Bachelor of Science and doctorate in pharmacy from the University of Kentucky, and has also been affiliated with Ohio University as a pharmacist and educator there. Welcome to you both. Glad to be on this screen and share this time. So let's get started. I like to say and ask, how is diabetes in your bio? How does diabetes touch your life? And you can tell us that if you would. Certainly does professionally and in many other ways. Representative Bentley, I'd love to start with you if you don't mind.
Yes, sir. Thank you for the privilege and opportunity to be here. I have diabetes, so it's a personal thing for me. No one in my family has diabetes, so it was kind of strange that I came up with it. I presented with diabetes after I had a blood transfusion, so figure that one. So ever since then, now about 15 years, I've had diabetes, and it's been of interest to mine. Also, I've served in the trenches like the doctor has. I've served in a pharmacy 44 years and had people get their insulin and walk out the door and buy their Milky Way and Pepsi. So I've been fighting it for 44 years.
Very well put, sir. Thank you. Dr. Alvarado?
Well, first of all, thanks for the introduction. It's great to be here. It's great to be with Representative Bentley, who's a partner on a lot of issues we're getting done in healthcare. I'm an internist and a pediatrician. And so in internal medicine, obviously diabetes in Kentucky is probably one of your main chronic conditions that you treat and have to know how to treat properly. And something throughout my entire career that, we've had to learn to manage. And we've seen kind of waves of just improved diagnosis, awareness, new medicines that are coming out all the time to help treat, and new types of insulin that have made it easier for patients to receive treatment, newer devices. And so it's been interesting to see the evolution from going from the rudimentary insulins that we were used to years ago into the newer ones that are available now, treatment options, awareness, diagnosis. We know that it's an increasing issue. We know with increasing obesity rates in Kentucky, we have higher diabetes rates in our state as well. So obviously, just from a everyday standpoint, I'm treating patients that I see with managing their diabetes. And then you look at it from a global perspective when it comes to healthcare policy for Kentucky, trying to get our state healthier, trying to reduce, we know all the side effects, heart disease and stroke and all the things that can happen with diabetes, the higher risks of, even with COVID today, if you have diabetes, your risks are higher of having a bad outcome. So we want to do the best that we can to help reduce that. So just patients that typically become friends and their neighbors and people that I know and take care of. And so you have an interest to get good outcomes for them. And, I would get on my patients' cases, Representative Bentley, and people would, they think, oh, this guy's mean, but it's because I care and I want to see them have a good outcome. The time that I stop getting on their case, I've kind of given up on their case. So for me, it's going to be a continual fight until we get this under control.
We appreciate your enthusiasm and your commitment and your determination to change things. Both of you are working on legislation, statutes that would reduce the cost for patients. Our champions need to know this. These could be hallmarks of this 21 session. Dr. Alvarado, could you share more about the copay accumulator bill and how it could help people with diabetes as well as all those with chronic conditions?
Sure. And I think to give credit where credit is due, I think Representative Bentley has run this bill in the House before. And so sometimes when we try to run bills through, the House has a lot more members, a lot more volume of bills. And so when you try to start them on that side, it's a more of a bottleneck trying to get them into committee and out. The Senate has less members. And obviously I chair a committee, so it makes it a little bit easier to start getting some of these moving in the right direction and having them heard. This one, though, did not get assigned to my committee, got assigned to banking and insurance, which doesn't meet there often in the Senate. So I'm glad that it's there. But the bill basically allows for copays. We know that you probably see advertised that you might have a copay, someone might have a copay associated with a medication of some sort, and the pharmaceutical company that offers that drug will offer you a coupon card or something to give you a bit of a discount when you go to the counter. What we've got now is with people with chronic conditions, typically, and chronic medications, a lot of the insurance companies will not allow you to apply that coupon card towards your deductible. And ultimately, when you have a deductible, it's a cost sharing mechanism. And so a lot of patients will say, hey, I've got a coupon card. My deductible might be $5,000, let's say, for the year. And the coupon card's with 100. We want to be able to allow that coupon card to be applied towards your deductible to help them in that cost sharing, because effectively someone else is giving you that money to help towards your healthcare costs. And so insurance companies have blocked that. We're trying to, in this bill, to loosen that up. And I tell people it's like getting a Christmas gift with a gift card for a restaurant. If you go to the restaurant, you present that gift card, it counts towards your meal. You don't expect to say, here's my gift card, and on top of that, I'm going to get the full cost to pay for that as well. It applies towards it. The same thing would go with our coupon cards when it comes to these medications. And it's typically not associated, the bill applies only to things where generics are not available. So there's no generic available. You have a chronic condition. These cards would apply for that. And 90% of our medicines that are right now that are being distributed are generic. So it would apply to about 10%, but people with chronic conditions like diabetes, rheumatoid arthritis, lots of things where they require specialty meds, this bill would allow these cards to be used and allow people to help with their costs. I mean, the pharmacist still gets paid, the insurance company still gets paid, and the patient gets their medication. So it's a win-win for everybody ultimately. And hoping to have this heard later this week. So we're looking forward to having the ball rolling, and hopefully once it gets to the House, Representative Bentley can pick it up there and get it over the finish line.
Excellent. Representative Bentley, how about your copay cap bill? Can you speak to what this means and how you're building on the progress of last year this year?
I presented the bill last year, and there was no votes in the House, and it didn't make it out of the Senate. But from the ground up, let me say this. Everybody know what this is? This is Atlanta's solar pen. And so I just looked up the price of it on one of those good RX type things. Cash would be over $500 for a box of 5 of these. If you had the special discount, this is still $336. So say we paid $336 and we were on a dose 150 units or less. This only lasted 2 days. Then you would need 9 boxes for 90 days. And 9 times 336, of course, is approximately, let's see, for a whole year, $12,000. Think about that. That's what that would cost people like me for a year. So with that in mind, and knowing that we have about 1.7 million Kentuckians with diabetes, and knowing the result of not controlling your diabetes and your sugar, we all know the kidney problems, the retina problems, the amputations, the stroke, heart death, and which we're always in the 40s in 1 through 50 of states, and especially Eastern Kentucky. I carry that on my shoulder all the time up here. Obesity in adults, obesity in children, you name it. So we carry that. But the cost of control, the insulin has tripled in price since 2002 to 2013. And most people realize that Eli Lilly did the basic research back in the first decade of the 20th century. You know, we use a lot of beef and pork. Aren't we fortunate enough to have human insulin now? You know, I used to worry about pork insulin causing a hypersensitivity reaction in a Hebrew family sometimes. And that's how far back I go, because they would never eat pork. And if they got a piece of hot dog at school, I had to worry about that. And I'm sure the doctor did too. So 100 years since insulin's been discovered. But if you really look at it, you know, 1 out of 4 people of those 6.2 million that use insulin, 1 out of 4, the cost factors, you know, you get increased rates to the emergency rooms and all these cost factors. So that if we could get this bill through, about 30% of Kentuckians would have a better controlled, managed disease. So most of them now, right now, without work and everything, most can't afford. So there's no we call this a drug, but really it's part of the endocrine system. And so it's really a hormone to latch sugar into the muscle. So, with that in mind, people are not getting a natural product of the body. They need this insulin to stay healthy and productive. And if we do this and we can lower this copay, then we can reduce the cost of complications that we see every day. And so, Colorado was the first state to present this bill in 2019. And since then, 13 have presented it, everywhere from $100 down to $25. So that's what this bill does. You can choose between insulin or rent, or you can choose between insulin or food or those people, or we can pass this bill and give them a smaller copay. And it is supported by the ADA. Thank you.
Thank you. Chairman Alvarado, many issues are relevant to the pandemic in your Health and Welfare Committee. It's well reported that COVID has had a disproportionate impact on a segment of our population, including people with diabetes or people with obesity. We generally, though, call it health inequity. How do you frame this up, and how do you see us addressing it as a state?
Well, I mean, that's a broad question. It's a broad topic. We've had a hearing in the interim about health inequities in the state, and there's, some would argue some of those inequities are rural-urban divides, some are racial divides, some go by disease states, is what some will claim as well. So that's a difficult question. We're trying, I think we're trying to take in listening to people like advocacy groups like this to make people aware. I think sometimes we get, as far as being in the medical profession, you get so used to just treating people, and you kind of get blinders on when it comes to treatment and trying to get policies out there. So sometimes you're unaware of disparities or inequities in the system, and so people have to identify those, and then you try to reduce those barriers. So I think just, again, some of these, when it comes to COVID treatments and that sort of thing, is just being aware. Sometimes it's education for individuals who aren't aware that, hey, I'm at a higher risk. Please take these necessary precautions. Obviously, getting vaccination rollouts is crucial. We're very dependent on the federal government in terms of rolling out those vaccines to every state. We have a lot of rural communities that right now have been clamoring, saying we see the urban areas getting thousands of vaccines, rural or not. We need some of those here. And so, again, we've had meetings where we've brought the Secretary of Transportation, the Secretary of Cabinet Health and Family Services to say, here's emails I've received, and I've read them on the record, and they claim that they're aware and they're trying to get those vaccines distributed. So sometimes it's just a matter of patience and trying to identify the highest risk individuals. And we just can't get the vaccines out quickly enough is what it comes down to. So it's awareness. It's sometimes it's a squeaky wheel getting the oil, and making sure that we're notifying the people that are in charge of that to get them out there. So we're not as quick as we want to be sometimes in healthcare. Things will move slowly, but hopefully as vaccines roll, we'll be able to start getting those out as quickly as we can, and just making sure that people are aware. Again, I think people with diabetes, again, there's higher risk. The older you are, the higher risk. We'll have to start categorizing those as they come down. But I would encourage everybody, if you haven't, contact your Walmarts now that's starting to get these vaccines, contact your health departments, let them know, even if you're not the highest risk, when they open up a vial, that they might have people that don't show up. And so they don't want to waste those doses. And if you're available, they can call you and say, if you can get here in the next 15 to 20 minutes, we'll give you a dose, and you can rush down there and get your first dose and get in the list. So we encourage people to contact and get in that queue. And if you have a chance, that you can get in there. But so much of it is dependent, unfortunately, on just production for the vaccinations. And but the topic of healthcare equities and disparities is broad, and we're working on that. There's a lot of things that we can do, and often it's chipping away and being aware. So if you see them, just notifying us so that we can identify those and start to work on it.
Great work, great answer. Both of you were on that task force together. Representative Bentley, you picked up an idea called Kevin's Law. You got it passed. Senator Alvarado helped you in the Senate. Governor Bevins signed it. We were there, Julie Babbage, Lauren Hogan, Dr. Rebecca Hartsoe, and I, for that wonderful and emotional bill signing. Share with people what Kevin's Law has meant.
For me, I used it a couple of times, to say the truth. So Kevin's Law is, if you're a diabetic or you're a person with need of albuterol for asthma, you could go into the pharmacy and get a 30-day emergency supply. Of course, Kevin was in Ohio over the New Year's Eve holiday several years ago, and he died because he didn't get his insulin. So his father and the ADA and Insulin for All people have always advocated for that Kevin's Law. But I've used it, went in, and so I've been out of town, and it's a great law. And a lot of other states have picked it up too. Talking about health equity and dispensing of the vaccine, the senator did an excellent job of answering that question. But pharmacies are within 5 to 6 miles of every constituent in Kentucky. We need to use the independent pharmacies to help get that vaccine out if they can get enough. And most of those pharmacists are already vaccinators. So it's a win-win thing. And second point is my mother turned 97 last week, and she's had both her shots. So I know what it is to deal with the elderly and getting their vaccines. So.
Very good, sir. In my 20 years of working on diabetes issues, I've seen many great bipartisan moments, and this has really become a nonpartisan issue. When Senator Tom Buford and Senator Alice Forty Kerr passed those two landmark bills in the Senate, it was Representative Ruth Ann Palumbo and Representative Joni Jenkins who took them across in the House. Tremendous cooperation, tremendous work together. How do you gentlemen build the coalition for diabetes action? How do you draw people together in your caucus and the other caucus and across the state?
Yeah, that's always, and it's always a difficult thing. You get people that I think expect things to happen instantly in government, and even amongst Republicans or amongst Democrats, there's often disagreements on things. And so on topics like this, it's often a matter of investment into a field of some sort, and requires sometimes monetary investments. And so we can advocate for things saying, hey, an ounce of prevention is worth a pound of cure. We've heard that, old adage, and it's true and it's accurate. We'll advocate for saying, hey, if we can just spend a little bit here, we'll get so much benefit on the back end. And we get a lot of blowback on that. We get sometimes from other members, and we've heard that before in other things, non-healthcare related, and we haven't seen that come to fruition. So they doubt the veracity of those statements when you're making them. So it's often convincing people of providing that investment and seeing back-end benefit. And the benefit may not happen for 10 or 20 years, which will be well beyond the time that politicians often may serve in these capacities. And so they want to see it, everybody wants quick results. Constituents want things happening right now. We want politicians with instant results as well. And sometimes you have to have a bit more patience to know that what we're investing in now will have long-term benefits. So it's trying to convince people of that. Again, I think you're right. And these are nonpartisan issues. Most healthcare things are nonpartisan issues. And sometimes they'll fall across those lines, but most of the time, I think we can reason with each other to say this is for the benefit of people's health overall. So that's what I've encountered to be the toughest things. And you realize that you count every vote in our committees. You don't just say, hey, I just got to have my members. You have to go to both sides and make sure they're okay with certain things. And you'll find that you'll have support on these issues, even when they get to the floor of the House or the Senate. So it's a matter of doing that, I think. And, in the meantime, you have people, I've had people that have sent me communications before saying, I've got this problem, you can fix it right now. And I'll try to provide saying, well, I'm trying, we can try to do this. In the meantime, here's a potential solution for you. I don't want you to be at risk. And then they take that as though I'm not advocating for their position. Had that happen, and can be frustrating because you're just trying to find, as a doctor, I'm always about fixing problems, and sometimes there'll be a temporary issue, and I'll think, here's something you can do in the meantime to get you over the hump until we get these things resolved. And again, some don't find that satisfactory. So it's difficult to balance a lot of those things, but we are trying to get coalitions built and make an awareness. And I think as people are aware, and really what really will drive a lot of legislators is hearing from their constituents. They know, hey, this is an issue, this is a problem, trying to get that across and understand that there are always other forces at work. And unfortunately, a lot of times those are medical insurance, companies who will say, hey, we're concerned about costs. And there are legislators who listen to that angle as well. So you're trying to always balance making sure that your policies are not going to increase costs for others, but going to get solutions done for those who are in need. So it's always it's always a tough situation, but I think as long as you can build coalitions, increase awareness, and constituents reach out to legislators, you can apply pressure and move the ball in the proper direction.
Outstanding. Representative Bentley, would you like to add to that? You had 90 votes and no votes a year ago. You're pretty good at building a coalition, we'd have to say.
We got about 50 co-sponsors this time. But what I try to do is find out who the leader is of the other idea. And so last year, I found out that Representative Booker was type 1 diabetic and Patty Minter's son is type 1 diabetic. So I went to them asking for help. And Patty's been a really good advocate in Western Kentucky. And of course, Booker and I still communicate about his disease state. So, you know, that's above anything a party when you're talking about diabetes. So that's how I went about that, because we're all human, we're all blood's red. And, you know, just like Dr. Alvaro, he wouldn't be a doctor if he didn't believe that, you know. So that's where I go to get my bipartisan stuff.
Julie Babbage is about to give me the hook, but before she does, how can our champions here today help you most? What one thing could they do to back you up, give you support, give you information, ideas, and messages from home? What matters most, Dr. Bentley?
Using facts. I found out that facts and truth are knowledge in Frankfurt. So if you got the facts, go to it.
Good.
I'd say volume, you know, again, communication is the key. A lot of people think that your legislators don't listen, or, you know, somebody's reading their emails. I can assure you, in Frankfurt at least, knowing the people that I work with, they read their emails, they look at their phone calls they receive, they listen. So if you don't know your state rep, if you don't know your state senator, I'd encourage you to get to know them, email them, let them know, tell them how important this issue is, because I can assure you there are other forces that might be represented in the state capitol that might have individuals representing their needs. Real people, everyday people that suffer with issues. I mean, most legislators I know of want to solve those problems for people back home. And so if you reach out to them, communicate with them, and, you know, the more they hear that, they'll come to their caucus rooms and say, I'm hearing this from people back home, I got to do something about this. That's how you're able to get things accomplished. So communicate with your legislators. That'll help, again, Representative Bentley when he's pushing for these issues to get them across the finish line, and myself in the Senate as well.
Well, Senator Alvarado and Representative Bentley, you are all stars for the diabetes cause. MVPs, most valuable politicians. We'll continue to rely on you and help you and back you up. Consider us your extended staff, give us assignments, and we'll work to come through. Thank you very, very much for your time today. An honor to be here.
Thanks for having us. I appreciate it.
Yeah, thank you very much. Thank you, Doctor.
Perfect. Thank you guys so much. And we will have you turn off your cameras and mute yourselves as we head into this next part of the conversation. This last panel really sets us up so well for that, because it's an overview of Kentucky government, from our congressional delegation to our state process. You'll see on the slide here in just a moment that Kentucky has 6 members of the House of Representatives, and like every state, 2 senators. If you're not sure where to find your representative, you can use this link at the bottom of the page for that information. And because today is focused mostly on the state legislature, Kentucky is one of a dozen divided government states where there is a split in party between the legislature and the governor. So on this page, you'll see a view of the dynamics in both chambers. Republicans have supermajorities in both House and Senate. So if Governor Beshear vetoes legislation, as has happened this session, the House and Senate have 2/3 of the votes needed to override with just a party line vote. If you're wondering who your state representative is, you can also use the link at the bottom of this slide to find out that information. In Kentucky, legislators convene for what's called the legislative session, which begins the first Tuesday in January and convenes annually for 30-day sessions in odd years and 60-day sessions in even-numbered years. So 2021 is a short session. This process wraps up around mid-April or so every year. And so that means really that legislators are in session for just a quarter of a year. Mostly that's the time that bills are going to pass. Senators are reelected every 4 years, representatives every 2 years, and we don't have any term limits. And because Republicans have a major advantage in number, there's some agreement on many issues in the majority but that doesn't mean that there's always agreement. Some of you may have seen last week's high-profile vote on historical horse racing that required Republicans and Democrats to push it through. And these dynamics are important in understanding the odds of a bill passing. You'll see here on the screen a little bit more on how a bill becomes a law. But if a bill is sponsored by a Democrat, and you're looking as an advocate to see that information online, it's going to need some Republican support since you need a majority of votes to pass legislation. So it's something good to be aware of. You can see the chance of passage based on who the sponsor and number of co-sponsors are. As Representative Bentley just indicated, over 50 co-sponsors is half of the legislature who's in support of his bill. That means it has pretty high odds of passing. The image here that you see, Bill from Schoolhouse Rock, is one that I've noticed has a 100% chance of making people smile, and usually somebody starts to hum the song. But in that song, Bill knows that he's one of the lucky ones, that most bills never get as far as he got, and that's true. There are over 14,000 bills and resolutions that were filed in the 116th Congress. So that was between 2019 and January of this year. And nearly 90% of them received no action at all. No committee hearing, no vote. And Congress is split when it comes to how it works, and it was designed to work slowly. But the exciting thing about state legislatures is that they receive a lot more action. And so here you'll see all the steps to that journey of when a bill is first filed to when it becomes a law. And action is required each time those colored boxes shift. And what's important here to note is that each color shift also represents a time when advocates can use our voices to make a difference. At the start, advocates can encourage a legislator just to file a bill. And once that bill is filed, it gets assigned to a committee based on the subject. So for diabetes bills, it could be health. But if there's an education component like glucagon in schools, it might go to education, or it could go to the budget committee if it requires funding. So a bill can never move again after that. It can just be assigned to committee, or it might come to that committee, in which case it is voted yes or no at that point. And the members of that committee are more inclined to vote if the community weighs in, yes or no. The way that we weigh in really does influence how they vote. So sometimes we're able to bring in advocates to testify in the committee to tell their story in support of a bill. And that's another way that Champions in Kentucky can be involved. If a bill then passes out of committee, it's heard on the floor, and more advocacy is needed to make sure that the full chamber, the House or the Senate, will vote to pass the legislation. And we ask advocates at this stage to write their representative, since every single member gets to have a vote. It could be to oppose a bill and vote no. It could be to support it and vote yes. And then depending on how the bill moves, the process begins again in the other chamber, the committee, the floor, more chances to advocate for votes. And then lastly, the governor gets it. We can appeal to the governor to sign it or to veto it. So there are lots of moments where hearing from you, hearing from us, the people back home, and the constituents makes a major impact in the process. And DPAC will help us to find ways to use voices when they matter most. And we'll get into that later on. I'd like to go ahead and switch, though, gears for our moderator for our health panel. While those panelists are turning on their cameras, I'm going to introduce to you the moderator. So Ed Hawthorne is the vice chair of the Diabetes Affiliate, or DPAC's affiliate organization, the Diabetes Leadership Council. He is a former chair of the board for the American Diabetes Association, and he served on several other boards, including the Red Cross and the March of Dimes. He is currently the COO and managing director and partner of CE3 Solutions, a champion for people with diabetes for decades. Ed is actively involved in the state of California, where he resides with his family. So Ed, over to you as our panelists turn on their cameras and their microphones.
All right, well, thanks, Julie. And before we begin this conversation, I want to highlight a few important notes and statistics for the audience. First of all, Kentucky was the first state in the country to pass a law to create a diabetes action plan, or DAP as it's called. This model legislation has since been passed in over 30 states. Kentucky has another first in the nation, the first state to officially license diabetes educators, a major advancement that has also been copied around the nation. Now, turning to some statistics on the state of diabetes in Kentucky, We have some slides with data on them that we can pull up that I think will be useful during our conversation. But more broadly speaking, from 2000 to 2018, diagnosed diabetes in Kentucky adults has doubled from 6.5% to 13.7%. But I think the percentages don't show justice. That's over 198,000 people to over 474,000 people, or 1 in 7. The total direct medical expenses for diagnosed and undiagnosed diabetes, pre-diabetes, and gestational diabetes in Kentucky was estimated at $3.8 billion in 2012. So now, keeping these in mind, I am now happy to introduce the rest of our panel. Dr. Laura Hieronymus and Ms. Elizabeth Good. So Dr. Hieronymus is an Associate Director for Education and Quality Services at the University of Kentucky Barnstable Brown Diabetes Center. She is also Adjunct Associate Professor for the College of Nursing at the University of Kentucky. She is board certified in advanced diabetes management and a master licensed diabetes educator. Dr. Hieronymus is an active member of the American Diabetes Association and the Association of Diabetes Care and Education Specialists, for whom she was honored as Diabetes Educator of the Year in 2008. Dr. Hieronymus earned a bachelor's degree in nursing, a master's degree in allied health and education, and a doctor of nursing practice from the University of Kentucky. Our other panelist is Ms. Elizabeth Good. Ms. Good is the Deputy Director of the Division of Prevention and Quality Improvement with the Kentucky Department of Public Health. Her role includes managing state public health initiatives to reduce the incidence and burden of chronic disease, as well as programs that increase access to healthcare services and resources. Ms. Good has her undergraduate degree in biochemistry and molecular biology from Centre College and a master's of public health degree from the University of Kentucky. Prior to the cabinet, she spent 16 years as a hospital policy advocate specializing in rural hospital and patient safety. So I want to thank you both for joining us. So central to DPAC's mission is patient access. So we'll start there. Ms. Good, you head the department that oversees prevention and quality improvement, focusing on chronic health conditions like diabetes. Within that is a diabetes action plan, which Kentucky led the way, as I mentioned earlier. And I want to thank you for your work on that annual undertaking, which I know is quite a process. You also manage the Kentucky Prescription Assistance Program, or KPAP. Now it's worth noting that DPAC consistently references KPAP as a national model for how states can improve access to the tools that people with diabetes need to manage this disease. Could you briefly walk us through the KPAP program and how it works?
Yes, thank you, Mr. Hawthorne, and I really appreciate the invitation for participating with you all today. As you mentioned, our diabetes prevention and control program in Kentucky is very robust and often a mentor to other states, and certainly a program that we look up to. And that also includes our KPAP program, our prescription assistance program. I'd love for Jacob to pull up a flyer that I want to make available to everyone today so that you can just have a visual of that program. But KPAP is a prescription assistance program. We utilize the prescription drug assistance program offered by drug manufacturers, other discount drug programs, and discount pharmacy programs. It's free to every Kentuckian in the state. We can help anyone that reaches out to us. How it works is we have a partner called Drug Assistant that has gathered and created a single portal accessing all prescription assistance programs available out there for any type of medication that a drug manufacturer might have an assistance program for. It's all in one portal, and we have trained professionals that assist Kentuckians into seeing if they are eligible for free or reduced cost prescriptions. How that works is we have a team here at the state that operates a hotline. And on the second page of this document, you'll see we have our hotline number. And what they do is comb all the drug programs to see if a patient who calls in is eligible. Now, eligibility is going to vary from one program to the next. But even if someone has Medicare or insurance of some kind, you may still be eligible for programs. So if you're having trouble accessing medications, whether it's related to your diabetes care or any condition that you may have, it's well worth checking with us to see if you do qualify. And in addition to the drug manufacturer programs that are available, say that you haven't met a deductible or one small aspect of being eligible, we also connect citizens to other more localized assistance programs that may offset some of those initial hurdles that you have to reach in order to become eligible. And then just to kind of wrap this up into a big picture. So we have folks here in Frankfurt that operate the hotline and help citizens directly. But also importantly, that you should know is that we also have a number of community consultants that train advocates across the state in various settings. It may be clinics, hospitals, local health departments, churches, all types of organizations. We've trained 274 advocates across the state to assist Kentuckians with accessing free or reduced drugs through this program. So just to point out, it's really important because we help lots of people with diabetes as well. In fact, last year, about 1,093 patients accessed insulin through our program, and the total value of the medications that we provided for free to those folks was $10,200,000.
Great. Well, thank you. And I do have one follow-on question, which sometimes people struggle around sort of qualifications and eligibility. And so I just want to make sure I understood you correctly in that this hotline could be the one-stop shop for people finding out about whether they qualify or whether they're eligible for these programs. Is that correct?
Absolutely. Absolutely. We would gather just some information, but also realize nobody has to mail anything in, fax anything in, fill out paper forms. We can work through that hotline process to assist people in just a simple phone call.
Oh, great. Well, thank you so much. Dr. Hieronymus, let's shift to you. Can you speak broadly on diabetes education and why it is such an important part of diabetes care?
Yes, I can. It is important. It's also essential. It's an essential component of care. In fact, a medical management plan for diabetes is considered inadequate if the patient does not receive education with that. It's important to keep in mind too that it's not a one-stop shop diabetes education. There are 7 self-care behaviors that are essential. The first being healthy coping. Diabetes is a lifelong illness, and so it's very important to develop healthy coping skills with that disorder so that you can really manage the diabetes and do the other self-care behaviors, which include healthy eating, being active, taking medication, monitoring, risk reduction, as well as problem solving.
All right, well, let's shift the discussion more broadly to the state of diabetes in Kentucky. And one thing that separates Kentucky from states in other regions is its rural populations. So you both have some perspective on that, given the roles and your background. So Ms. Good, let's start with you and how the cabinet is working to include rural populations in its programs and outreach with KPAP specifically or more broadly.
Thank you. Well, our diabetes prevention and control program, in addition to how we mobilize community coalitions, provide education, networking, and resources, we also conduct surveillance of diabetes information and data. And we use this to evaluate the challenge that we face with serving our patients, and also to look at how effective we are in addressing those challenges. And part of that surveillance tells us that we do have pockets of more severe challenges in accessing healthcare across the state. And this is certainly a challenge for diabetes. Again, what we're finding is that we know that availability of insurance, the high cost of long-term chronic disease to patients, and the recent changes related to the COVID-19 epidemic and a lot of other environmental challenges that we face often makes accessing healthcare a real challenge for some areas in the state, whether it's Eastern Kentucky or other areas of the state that have socioeconomic differences. So what the KPAP program does is recognize all the nuances of any patient that we're trying to serve and really try to address exactly the needs of that patient, especially understanding that there are comorbidities often related to a diagnosis of diabetes. So we try to treat the whole person through the KPAP program. It's not just a diabetes medication program, but all types of medications.
So gathering surveillance in these rural populations must be a difficult challenge. So what do you use and how do you gather that information?
Well, one of the most important tools that we have in Kentucky is called the Behavioral Risk Assessment Survey. And this has actually been started by the Centers for Disease Control and Prevention. We call it BRFIS here in the state. Every state has a similar survey, and there are standard questions that the CDC requires us to ask. And then on top of that, we can add some unique, specific to Kentucky questions. This is really the gold standard for healthcare and health status surveillance in every state, and certainly in Kentucky. So it is basically a phone survey of Kentuckians, and we ensure that we have a high enough number of responses each year so that we know that that information is statistically valid. And we use this data to also gather information about patients with diabetes, whether they've been told that they might be pre-diabetic, if they have an actual diagnosis, and we can gather information about education, other illnesses they might have, and how they access care. And we use this information to design our diabetes prevention and control program activities in lots of other health-related programs that the Department for Public Health uses, as well as in looking for other resources and partners that we can engage with to address the healthcare challenge of Kentuckians.
Great, thank you so much. Dr. Hieronymus, telehealth has been touted for rural populations, and DPAC has worked to expand access during the pandemic. Is telehealth a supplement to the education model, or could education be delivered entirely remotely?
Well, to answer that question, I would say it's a supplement. However, in most cases, we can deliver diabetes self-management education and support services via telehealth. It's important to look at, from a patient perspective, considerations. For example, we treat patients and see patients and educate patients across the lifespan. at the Barnstable Brown Diabetes Center. And so we may have a little, very small child that's new onset diabetes that really needs to come in. And we work with the parents, support them, educate them. So in some situations, we need to do that, especially initially. However, we also, for example, are working with a rural area in Western Kentucky that's several hours from our site in Lexington. And we are able to bring those individuals into a particular healthcare facility and deliver the education there. I mention that option because we also have to consider the internet. The internet needs to be viable for patients to engage via the telehealth platform. It's more difficult if you try to do telephonic or just using the telephone for education. There's a lot, as you might guess, of demonstration, teach back. I show you, you show me, how to do a certain task. So I think that's really important, but I do think we've moved to a model that education can primarily be delivered via telehealth. And then certain circumstances, we would work around that.
So would you say or suggest that if telehealth is going to be sort of a viable delivery mechanism for us ongoing for education, that we should also be advocating for internet access, broadband access, and all things, because without that, it seems like telehealth doesn't work without that capacity.
Absolutely, and I agree 100% with that, because we do need the viable, internet service that you can trust, that again is viable and reliable. It works great. For example, this meeting today, we're all in different areas, different places, but we're meeting and we're all engaged. We're listening, talking in some cases, and being able to interact. And it's similar to how the telehealth platform works. We use Zoom for our platform at the University of Kentucky. It also is a secure Zoom for healthcare purposes. But in some areas, if the internet access is difficult, we can partner with others and healthcare facilities, and the patients can come there and actually be close to home, yet receive the education from our service. Great question.
Thank you. Dr. Arons, another question for you. Given your career as a diabetes educator, are there any misconceptions around diabetes education that you and your team frequently address with patients or others?
Again, another very good question. And I'll echo Representative Bentley when he said, bring me the facts. So I think it's really important to understand that all information out there is not necessarily true and valid. So when you see a diabetes educator, you're coming to the office or working with that diabetes educator via telehealth, and you are seeing them with evidence-based information. We are presenting the facts. And those facts change over time. New research will update our curriculums. We learn new things all the time. We use a lot of technology with diabetes. And so it's really important that the patient fully understand not only how to use it, but what to do with the information that it generates.
Well,
so very important.
I'm sorry.
Go ahead.
Down the same line, so for patients who are really good on the internet, love to do research, so they're researched about their condition, they're finding all this information, what would you recommend that they do that? So it's one thing to look at it, find all this information, but the other part is that it has to be validated somewhere, right, to be true.
Mm-hmm.
Like so
Mm-hmm.
you suggest that they continue to do that, but also validate it, or what would your recommendations be?
I have two. I'll narrow it down to two. The first one is to teach and train patients and provide information about what is a valid site. What is a valid internet site? So we've talked a little bit about the American Diabetes Association, the American Association of Diabetes Educators, which is now the Association for Diabetes Care and Education Specialists. Those are a couple that are valid evidence-based sites. So I think that's important. train our patients what to look for, how to look for it to make sure it's valid. The second thing is for us to make sure that we are providing that top level evidence-based information. Sometimes I'll ask individuals when they come in, I'll say, well, tell me what you know about diabetes. So whatever they've researched or looked for or information that they have, if they tell me what they know, I can clarify that information, take the myths or the things that maybe aren't evidence-based and help explain what is. So in other words, help kind of turn the curve, if you will, and help them understand that, well, this may sound reasonable or sound good. The evidence state that, so I'm helping them understand what's true and reliable information. So I think that's key.
Thank you. Ms. Good, what do you think are the highest or the biggest challenges or misconceptions around KPAP?
I think that people assume that it's too good to be true. I used to provide a lot of education in my last career path. And we always joke that if we offered a free program, we didn't have as many people sign up for the program as we did as if we charged for a program. Mm-hmm. So I think that when you say something is free like this and that we're here to help you, people think it's almost too good to be true. The other thing is just getting the word out. And that's where I want to call on everybody participating today. You are all advocates on behalf of people with diabetes in Kentucky and beyond. And KPAP can be an amazing resource for folks with diabetes, but also anyone that or come in contact with that may have a condition, a disease, or a chronic disease that they are managing and having a challenge financially doing so. So I'm calling on everybody participating today to walk away with our hotline number and with what you've learned about KPAP and what we're capable of, and share that out with those that you meet and work with. And then finally, we always love to add more advocates to actually assist patients in accessing their medications. So if you're a part of an organization locally and you would like to become involved, you can also call our hotline and we can get you set up and trained, and hopefully you can help others in your area as well.
Oh, great. Now, lastly, as this is an advocacy forum, I need to ask you both what challenges you might face in your work and how can the advocacy community help? We'll walk through a lot of policy areas later on this call, from copay accumulators and caps, like we've heard so far, to non-medical switching, Medicaid coverage, and other barriers to access. So, Dr. Hawthorne, we'll start with you.
Thank you. So I think that from my perspective, the advocacy for diabetes self-management, education, and support is key and very important. And diabetes education, as I mentioned earlier, is ongoing. So not only at new diagnosis, but even at once a year, as data, research are presented, and some of the standards might change. So it's important for patients to keep up with that. And a good way to do that is through diabetes self-management education. Also, if they have complicating factors, hate to call this a complicating factor, but if a woman gets pregnant and has diabetes, it's very important that that woman is educated because things change during that window of time. And then if there's any sort of life transitions, changing to technology, we talked about that earlier. We want to make sure our patients have the availability of technology, should that be an important part of their plan. So all of the above are important. I think one other example that I'll mention is we have a pediatric population. We have, again, pediatric, adult, pregnant women, anyone with diabetes pretty much, and pre-diabetes. And I think that one of the things we do with our pediatric population is a diabetes medical management plan for them for school. The parent requests it, And we have to have that in place. And we often see the formulary, different formularies will change at the beginning of the year, which means every child with a change in formulary has to have a new, or at least an updated, I'll say, medical management plan. And that's disruptive and could even create gaps in care. So I think we need to look at the big picture for all people with diabetes and just really make sure we advocate for what is best for the patient, the person with diabetes.
And Director Good will turn to you, the same question.
Thank you. I think one thing that I've heard from each panelist today is that there is no silver bullet. There's no one single answer to this challenge that we face. And we really need to gather every resource available to us in order to provide the best care, to prevent diabetes when possible, and to access all the resources those folks need. So I think that we have a lot of wonderful solutions and resources when we come together, and opportunities like this allow us to showcase them. So I'm very proud of the work that the Department for Public Health does related to being fit and healthy with our physical activity and nutrition program, which works right along with our diabetes prevention and control program in the DPH, the work that our diabetes program staff does, and then how we link that to the work that's done in KPAP and accessing medications. So I think if we can learn anything and we take anything away from today and all the work that's being done, is that we have to break down all the silos of how we address things and how we carry on our mission, and really build on all the great things that we're all doing, the work that's being done by advocates and physicians and health departments and community activists and parents and patients. And so opportunities like this where we can bring all that information together and partner and overlap as we have opportunities is our best way to move forward.
Great, thank you. And we have a little time, and we have a question from the audience from Mary for Dr. Hieronymus. And her question is regarding what can be done to lobby Kentucky Medicaid to cover diabetes prevention, specifically pre-diabetes.
That's a very good question. And there is actually a work group, a state work group that is working towards trying to have the diabetes prevention program, which is a 12-month program to prevent or delay type 2 diabetes. And it works. It's evidence-based, as we mentioned earlier. So I will tell you there's work behind the scenes for that. We have a couple of pilot projects where we're looking at individuals in certain counties utilizing the diabetes prevention program, partnering with our county extension agents, many of whom are dietitians and nutrition experts. So we're looking at that so that we can show those data, have that information, and show them that it works. And just because we are now doing that primarily virtually because of the nature of the pandemic. So it's actually been good for us to look at that from a project perspective. So I hope that answers your question. There is stuff, if you will, being done, and those are some examples that take some time, but we will get there, and we will advocate for that to happen. So again, thank you for that question.
Great. Director Good, anything to add to that?
No, I think that Dr. Hieronymus covered all the bases there.
Okay. Well, I want to thank Dr. Hieronymus and Director Good, not only for joining us today, but also for the work that they do each and every day to make a difference in the lives of others, especially people living with diabetes. And let me also thank all of you for attending this panel and supporting the important work of EPAC.
Awesome, guys. Thank you so much. And really, they did an excellent job summing up everything we covered today in those 3 words, which is your voice matters. We're right on time, which is really exciting. I'm just going to quickly go through these next steps, which you've heard, and we'll say them again. Sign up on our website. Here's our social media. Please follow us, spread the word, and recruit people that you know to be advocates. More voices gives us more power. And of course, take action to tell your story. Thank you again to those of us who joined us here on Zoom and on Facebook. We hope that you've learned a lot. We hope that you've enjoyed this event. We hope you're staying safe in all of this crazy weather that we're having. We'll follow up with you with materials and links from today. And thank you so much. Just one more time again, we're really excited to build this advocacy community in Kentucky, to continue to be involved with the legislature and with Congress so that we can get the action that we need for people with diabetes. So thank you so much and have a great rest of your day.